Welcome to the AETCM, the Emergency Medicine channel. Today I will be briefing about you about the Lidocaine, one of the most common drug that we come across in our emergency department. So as all of us know, what is Lidocaine? Lidocaine is a class 1B anti-arrhythmic agent. So this you should never forget. What is the class of drug? This is a 1B anti-arrhythmic drug. And what is its mechanism of action? So coming to the mechanism of action, basically it suppresses the automaticity of the conduction tissues in our heart. That is, it would increase the electrical stimulation threshold of the ventricle, of the conductive systems, that is the Purkinje system, the ventricles, and thereby what it will do is it will block the initiation and conduction of the nerve impulse by decreasing the neuronal membrane permeability to the sodium ions. So basically if you tell, it is going to act on your sodium ions. So basically it will decrease the permeability of the neuronal membrane to the sodium ions and thereby inhibit the conduction of the neuronal impulses, and thereby it will suppress the automaticity of the conductive tissues in our heart. So that is what about the mechanism of action. Now coming to the pharmacokinetics, that is, we will be dealing in pharmacokinetics, the onset, duration, the metabolization, half-life and the excretion. So coming to the onset of the action of the drug, it is about 45 to 90 seconds. 45 to 90 seconds is the onset of action, and its duration is 10 to 20 minutes. You have 10 to 20 minutes duration of action, and it will cross the blood-brain barrier, and metabolization is done via CYP1A2 and CYP3A4. So these are the metabolizers, CYP1A2 and CYP3A4. Now coming to the half-life of Lidocaine is, its half-life is 1.5 to 2 hours. And excretion is via urine. So this pharmacokinetics is very simple. The onset will be 45 to 90 seconds, duration will be 10 to 20 minutes, it will cross the blood-brain barrier, it is metabolized by CYP1A2 and CYP3A4, half-life is about 1.5 to 2 hours, and it is getting excreted via the urine. So this is the pharmacokinetics of Lidocaine. Now coming to the next part, that is where we use Lidocaine in our ER. So the main places where we use is what? As an local anesthetic. So that you shouldn't forget. So basically we use in ER it as local anesthetic agent. So this is the most common use. Second is in cases of arrhythmias. Third, in case of cardiac arrest. And also we use Lidocaine for bronchodilatory effect. So these are the most common uses of the Lidocaine. All these 4 uses are the most common. Now coming to the formulations of Lidocaine, you know that Lidocaine we will get in different type of formulations. So the first and most common formulation what we know, it is in the you have the jelly form. So you have the gel form. So here in the gel form it is 2% Lidocaine. 2% Lidocaine will be there, and in one tube there will be 30 grams of Lidocaine gel. Where do we use this gel form? Mainly we are using the Lidocaine gel form where all? For putting the Ryle's tube, for inserting the Foley's, for doing bronchoscopy, endoscopy. So it has a local anesthetic property, along with that it has a lubricant property also. So those places we prefer the jelly form. The Lidocaine jelly form will be giving. Then the second formulation is we have sprays. Okay. So each bottle of spray will be containing 10% Lidocaine. Of that 50 ml will be there. 50 ml will be there. It will be of the concentration 10%, and 1 ml will be containing 100 mg. So if we are giving 1 puff, then it will contain 10 mg. 1 puff will be equivalent to your 10 mg. And then where do you use these Lidocaine sprays? In the dental procedures, when you have some suturing in your oral cavities, for indirect laryngoscopy, all these things what you use is the sprays. So one is the jelly form, the second is the spray form. Now coming to the third one, where do we use, what is the third one? It is the vial form. You know, as vials, when you see the Lidocaine, there will be two types of vials you can see. The clear vial will be there, one clear vial, and the other one is the darker vial. So the clear vial, if you take, the difference is that it is only the 2% Lidocaine. Only 2% Lidocaine will be there. And the darker one, you know, 2% Lidocaine will be there, along with that adrenaline also will be there. That is 1:2 lakh concentration adrenaline will be there. 1:2 lakh concentration adrenaline also will be there. That is the two types of vial forms. And why do we have a combination of adrenaline? Because adrenaline is a potent vasoconstrictor. So when we use this adrenaline, what happens is, in that local area vasoconstriction will happen, and only the local availability of the Lidocaine will be more in that area. So we only want very less amount, low dose of Lidocaine. So that also is there as a formulation. And where do we use these vials? We use for giving the blocks, we use for suturing, wound debridement, for putting the central line, for putting the arterial line, for ICD insertion. All these procedures we give it as a local anesthetic. So mainly through three formulations. Jelly form we have the sprays, and also we have the vials. And coming to the vial, the dosage, here already we have mentioned the dose. So here the dose will be 4 to 5 mg per kg. So the dose is 4 to 5 mg per kg, and here 1 ml will contain 21.3 mg. 1 ml will be containing 21.3 mg of Lidocaine, and its duration of action will be 30 minutes to 120 minutes, and a maximum dose of 300 mg per day can be given. So that is about the vials what we use. So this is about the local anesthetic usage of Lidocaine. Now coming to the arrhythmia. So when you take the arrhythmias, so in the ER we will always be using Lidocaine. So in cases of shockable rhythm, following the third shock and following the fifth shock, we usually give the Lidocaine. And post the third shock, what is the dose? Post the third shock, it will be, what is the dosage of Lidocaine? It will be 1 to 1.5. That is the dosage will be there. 1 to 1.5 mg per kg will be given. And following the fifth shock, how much is the dose? Half the dose will be given, 0.5 to 7.5 mg per kg is the dose. So here we give the Lidocaine. And if you are supposing to start an infusion for the arrhythmia, what is the dose? 1 to 4 mg per minute. 1 to 4 mg per minute will be your dose. And if it is pediatric dose, then the dose will vary from 20 to 50 micrograms per kg per minute. 20 to 50 micrograms per kg per minute. This is the pediatric dosage. So now if you don't have an IV access, if you have only ET tube, then the dose will be 3 times of the normal dose. And if you don't have an IV access but you have an IO access, it will be always equal to the IV access dosage. So this is what is the dose we give in cases of arrhythmia. Following the, if it is a shockable rhythm, following the third shock and fourth shock we will be giving, and if it is through ET tube, 3 times of the dose, and if it is through IO access, it will be equivalent to the IV access dosage. So that is what we will give in the arrhythmia. Now the third one, so we will have dealt with arrhythmia. Now coming to the bronchodilatory thing. So in the bronchodilatory, as we know, we will be taking 4 ml of 2% Lidocaine plus 4 ml of 0.9% NS. So this we will be taking and using as for the bronchodilation. for nebulizatory effect will be taking this. So, these are the main uses of the Lidocaine. Now, coming to the warning of Lidocaine, when we use Lidocaine, some warnings are there. That is, if we are using continuous intra-articular infusions, then you should be aware that it can cause chondrolysis. Intra-articularly, if you are giving infusions, it can cause chondrolysis. Second is, it can also cause methemoglobinemia. So, it can also cause what? Methemoglobinemia. Now, coming to the contraindications. So, in which all places is Lidocaine contraindicated? So, if there is some hypersensitivity reactions to the formulations, then you have, it is completely contraindicated. Then in cases of any AV block, second degree complete heart blocks, in case of heart blocks, then in case of any accessory pathways, WPW syndrome, in all these cases Lidocaine is completely contraindicated. So, main one is the hypersensitivity, AV block, heart blocks, accessory pathways, WPW syndrome. Then if you are giving in as spinal anesthesia, then if there is that local site, any infection is there, or if there is some ongoing hemorrhage is there, sepsis is there, in all these cases also Lidocaine will be contraindicated. And then we will be dealing with what? Next will be the adverse effects of the Lidocaine. So, coming to the adverse effects of the Lidocaine, in CVS what can happen due to the Lidocaine? Even though it is having an anti-arrhythmic effect, it can cause what? Bradyarrhythmia. So, while giving, that is why we told it is contraindicated in cases of AV block and the heart block. So, it can cause what? Bradyarrhythmias. Coming to the CNS part, it can cause what? There can be headache, there can be irritability. Okay, mainly headache and irritable are the common ones. Then it can also cause dizziness, it can cause anxiety, it can cause seizures, and also in severe forms it can cause coma also. So, these are the CNS complications. Coming to the respiratory system, it can cause bronchospasm, and finally it can lead to respiratory depression. Respiratory depression and bronchospasm can happen. Then if you look, patient can also develop peripheral neuropathy, and local side they can have thrombophlebitis. Can be there. So, these are the most common complications, that is bradyarrhythmia. In CNS part they can be headache, irritability, dizziness, anxiety, seizures, coma. Respiratory system they can be bronchospasm and respiratory depression. In peripheral neuropathy can be there, and also local site it can cause thrombophlebitis. Now, coming to the Lidocaine toxicity. So, due to Lidocaine, patient can develop headache, irritability, some metallic taste, arrhythmias, seizures, everything. So, when the patient develops seizures, when the patient develops arrhythmias, when patient develops cardiac arrest, then it is Lidocaine toxicity as such. So, when these three features are there, when there is seizure episodes, arrhythmia, cardiac arrest, then it is Lidocaine toxicity. And when you suspect Lidocaine toxicity, what you should do first is, if there is an ongoing infusion, you have to stop the infusion and then connect the patient to a cardiac monitor. This is very much important. So, as soon as you know, stop the infusion, call for help, and then you will connect the cardiac monitor. Now, if the patient does not have an IV access, you will be putting an IV access. If there is some hypoxia, respiratory depression in the patient, then you will be connecting the patient into oxygen. Hypoxia, then you will be connecting the patient to O2. And then if the patient develops seizures, then you can correct the seizures with benzodiazepines or propofol. benzodiazepines or propofol you can give. And if the patient is developing arrhythmias or the cardiac arrest, in case of arrhythmias, if it is a shockable rhythm, you have to keep in your mind that amiodarone has to be given, never give more of Lidocaine. If there is a third shock, fifth shock, never give additional doses of Lidocaine, you will be only giving amiodarone. In case of cardiac arrest also, we will be starting the CPR according to the ACLS algorithm, but never give additional doses of Lidocaine to the patient. So this is the main thing. So you will be stopping the infusion, calling for help, then you will connect the patient to the cardiac monitor. If there is no IV access, connect the patient, get an IV access. If there is some hypoxia, correct the hypoxia with the O2 correction, and then if seizures, patient is developing seizures, give patient benzodiazepines or propofol. And in case of arrhythmia and cardiac arrest, always follow the ACLS algorithm, but there you shouldn't give additional doses of Lidocaine. And then you have the antidote for the Lidocaine toxicity, that is the 20% emulsion you have. So 20% lipid emulsion you will be giving. If the patient is more than 70 kg, 100 ml bolus you will be giving, 100 ml bolus over 2 to 3 minutes, which is followed by 250 ml over next 15 to 20 minutes. If the patient is less than 70 kg, then you will be giving 1.5 ml per kg bolus over the 2 to 3 minutes, followed by 0.25 ml per kg per minute for the next 15 minutes. And the maximum dose that you can give will be 12 ml per kg IV dose. And following a seizure episode, you will have to monitor the patient for 2 hours, and following an hemodynamical instability, patient should be monitored for the next 4 to 6 hours. So you have to keep in your mind that what is the antidote for the Lidocaine toxicity? It is always your 20% lipid emulsion, and the dose is also you have to remember. So hope all of you have understood about the Lidocaine toxicity.